Good evening, everyone, and welcome to this Transplant Australia webinar. Tonight, the subject is COVID vaccination and for young people, and an update on the latest intelligence that we have from Australia and overseas on the impacts of COVID on young people. We've got a fantastic panel of extremely well qualified speakers this evening, and they will be in the capable hands of Dr. Natasha Rogers, who's the head of transplant at Westmead Children's Hospital. And I will leave Natasha to introduce the other speakers on the panel. I'm a board member of Transplant Australia, and my particular interest is the Living Kidney Donor Program, where we provide education and support for live donors. I have a particular interest in this topic. We have a teenage son who, through his teenage years, was a patient of Fiona Mackey's at Randwick Children's Hospital. And soon after he finished HSC, his kidneys failed, and he was transferred to the adults hospital at the Royal North Shore, and he underwent a transplant at the age of 19. That was 4 years ago, and thankfully he's well. He's just this week completed university, but my wife and I, and my wife was the donor, we're acutely aware of the concern that parents and families have about the young people, and even more so during this time with COVID. And we know the hunger and the interest that family has in getting up-to-date information. So I know that there's a lot of interest in this topic. We have received a lot of questions. Please, if you have further questions, use the Q&A tab at the bottom of the screen, and Natasha will direct those questions to the speakers at the end, and hopefully we'll get through as many as we can. I'll now hand it over to Natasha to facilitate and introduce our speakers.
Thanks very much, Cohen. Welcome everyone to this fantastic seminar that has been convened by Transplant Australia. I'd also like to recognise the contribution of the Transplantation Society of Australia and New Zealand, as well as the Transplant Nurses Australia. I'm coming to you from Orange in Western New South Wales, which is the home of the Wiradjuri people. Just before we start, I'd like to acknowledge the traditional owners of the land, as well as the leaders past, present and emerging. So as Colin said, we've got three fabulous speakers tonight, Fiona Mackey, Michael Storman and Rob Carroll, and they will speak first, and then we'll have a panel discussion, and we'll try and get through as many of your questions as possible. I'd like to now introduce Fiona Mackey, who is a paediatric nephrologist at Sydney Children's Hospital in Randwick. She's also a counsellor. She's the honorary secretary at the Transplantation Society of Australia and New Zealand, where she took over from my counsel position, and she's doing a fabulous job. Thank you very much, Fiona.
Thanks, Natasha. So I thought we'd start tonight with giving you a bit of a flavour of what COVID looks like internationally and in Australia for paediatric kidney transplant recipients and patients on dialysis waiting for a transplant. Next slide, please. Next slide. So there's a bit of data in paediatric kidney transplants from USA and from the UK, and we just have to bear in mind that most of this published data is actually predating Delta variant. So there are small numbers of infected paediatric kidney transplants. Only about 8% of patients required admission to ICU, and 100% only had self-limited disease, meaning that they all got better, and thankfully there were no deaths, and there was only a 4% rejection rate. From the UK, they only had small numbers that they reported of patients with paediatric kidney transplants who were affected by COVID, and they also had good outcomes. So the one good thing that we can tell you about is that, generally speaking, COVID-19 is a milder illness in paediatric kidney transplant recipients and dialysis patients than compared to adult kidney transplant recipients. But serious illness can occur, and we know that immunosuppression and kidney disease are well-documented risk factors in adults, so we do expect that that does convey some risk in children as well. The Israelis published their experience with COVID, and they followed a group of young children and young adults with kidney transplants and kidney disease. And during this period when they followed them, it was over 3 months, they found about 20% of their patients became positive for COVID. Now, they looked at what the risk factors were for developing COVID, and the more people there were that lived in the house was a risk factor, and being exposed to someone infected at home was the other major risk factor. 37% had no symptoms at all. Only one had moderate disease, and the rest thankfully had mild disease. And kidney function remained stable in all of them. It's important to remember that having COVID once doesn't mean that you can't have it again. And so 3 of those patients actually had a recurrence of COVID, or they got another COVID infection. Next slide, please. So this is really sort of hot off the press data about the Australian paediatric kidney experience with COVID. And so this data has been collected from around the country. And so the only cases that we've seen of COVID in paediatric kidney patients have been in New South Wales and Victoria. And I might just go through this slide a bit. So we've had a total of 7 in New South Wales. 6 out of the 7 were transplant patients. 1 was a dialysis pre-dialysis. And the age range of the affected patients was from 6 to 18 years. Now, what you're going to see is a very recurrent theme on this slide. The affected patients had no doses of COVID vaccines at the time of their infection. Okay, they were completely unvaccinated. That is for a variety of reasons. Some of it was that their infection predated the availability of vaccine. Some were too young to be eligible for vaccine, and some had declined vaccination. Thankfully, there was a full recovery, but 2 out of the 7 required intensive care admission. And the important point about those that needed to go to intensive care were that they were the older patients. They were the ones much closer to 18 years of age. And what you'll see again is a recurrent theme that the source of infection has largely been unvaccinated family members. So 6 out of 7 were from unvaccinated family members. Only 1 patient out of the New South Wales group, in fact, 1 out of the whole country, has been from a vaccinated family member. So there has only been 1 case of that, and that person had, the parent had received 2 doses of vaccine. In Victoria, they've seen 4 cases. Half of them were in transplant, half in their patients about to start dialysis. Similar age range, and again, none had received COVID vaccines. And again, they've all made a full recovery. And the source of infection was either unvaccinated family members, or in one of them, an unvaccinated neighbour's child. No other state has experienced any other COVID in their paediatric kidney patients. So COVID vaccination, well, we know there's good data and fairly extensive data in adult transplant patients. to say that COVID vaccines do reduce the duration and the severity of COVID infection. They do reduce the risk of transmission. They do reduce the risk of severe disease, up to 10 times lower risk of death. They're safe. They don't cause rejection. But what we're learning is that most people, most transplant people or immunosuppressed people need 3 doses. And we're just going to spend some time going through that tonight as to why that is. So if you have a look at the graph on the left, the bars are actually looking at the percentage of patients who developed significant enough antibodies thought to sort of be effective COVID vaccination. So you can see that, and the grey bars represent adults and the arrows are representing the paediatric data. So you can see that before the second dose in adults, less than 10% of transplant patients have got the right level of antibodies. But before the third dose, so after 2 doses of vaccine, you can see about 40% in adults have adequate antibody response. Now, those levels, the paediatric data that we have show that kids actually do mount a better antibody response than adult transplant patients. So the first arrow you can see before the second dose in paediatrics, that level is actually about 55%, and before the third dose it's closer to 70%. And if you then look at the very final bar, you will see that in the adults that there's close to 70% of them have significant, sufficient antibodies after 3 doses of vaccine. And it's from this data and some other studies that have informed us basically to say that you do get a better response after a third dose, and that you do need it because even after a third dose, the number of people with those sufficient antibodies are 70%, which, as you know, is much lower than the normal population. Next slide, please. So just to review why that is that you don't have as good a response to vaccinations with transplantation. Normally, when you give a vaccination, COVID here, for example, you need 2 things. Well, first of all, you need to make antibodies, and it's your B cells that make antibodies to the COVID. But you also need to have good functioning T cells to basically find virus and attack virus and kill virus. And if you have that combination of things, you'll have a successful immune response. Next slide, please. But the reason it's ineffective in some transplant patients is obviously we've deliberately knocked your immune system around so that you don't recognise the new kidney as being foreign. And so you don't have enough B cells, so you won't produce enough antibodies to the vaccine, and you don't have enough T cells to help fight off virus. And that's through the medications, and there might be other medical problems that can affect that response to vaccine. Next slide, please. So who is at risk of developing less antibodies after COVID vaccination? Well, this was a paediatric study, and they looked at Pfizer vaccine, and they found the risk factors for not mounting as good a response were having a drug called rituximab. Now, that's not surprising to us. It's used in induction or used to treat antibody-mediated rejection in some transplant patients, and it wipes out all your B cells. So it's not surprising then that you don't respond as well to the vaccination. But also having very poor kidney function. So if you're losing your graft or you are just before needing a transplant, that's a risk factor. Or if you're longer after your vaccination and the effects worn off. Next slide, please. And also it's been found in a paediatric study that if you were on higher doses of mycophenolate or taking more of it, that you were less likely to respond to vaccine. Now, please don't take away any point there that you should alter your immunosuppression times drugs at the time of vaccine. That's not what to do, but it's extra ammunition as to why you need to have a third dose of vaccine. Next slide, please. We'll skip over this one. Next slide, please. So having a vaccination is a bit like wearing a seatbelt in a car. You're really going to have a lot less of an injury if you've got your seatbelt on, but it doesn't mean you're not going to have any issue at all, and you'd really rather not have the car accident in the first place. So other measures are really important, and remember that, you know, the data of 73% after 2 doses, for example, in paediatrics means that 1/3 may not have an adequate enough response. And so that's why measures like mask wearing, and please wear it properly, and physical distancing and hand hygiene remain very, very important. Next slide, please. So onto the guidelines for the 3rd dose. So that the national body that looks at this has recommended all over 12 years of age with solid organ transplants or on long-term dialysis receive a 3rd dose. And an mRNA vaccine, Pfizer or Moderna, is sufficient, and that is to be given 2 to 6 months after the 2nd dose of vaccine. So that's not the same as booster shots for the normal population, which is 6 months after. These can be given 2 months after, and they should be, you should go and get those as soon as possible. Next slide, please. But here's another point to make to the rest of the family members, that you need to have your booster shots too. This study looked at what happened in terms of your risk of getting vaccine of COVID and when you were vaccinated, and you were more likely to get COVID if it was a longer period of time since you were vaccinated. So it's now been decided that we need booster shots at the 6-month mark after your 2nd vaccine. And again, it's very effective. And this is an additional way to protect your child from the risk of COVID as well. Next slide. So in summary, COVID disease is generally milder in paediatric kidney transplant and dialysis patients than adults, but we have had a couple, the older teenagers, who've required ICU admission. The major reason we saw it was family members not being vaccinated. Vaccination is safe and gives you the best protection against COVID, but it's not perfect, so we still need the other measures, masks and distancing and hand hygiene. Because there is less of a response being immunosuppressed to vaccination, everyone should have 3 doses. And it's additionally important to protect by ring vaccination. Vaccinate everyone around your child who deals with them, who can be. Thanks very much.
Thanks very much, Fiona. We'll leave the questions till the end of the session when all of the speakers can contribute to the discussion. So next I'd like to introduce Michael Storman, who's current Director of Liver Transplantation at the Children's Hospital at Westmead. Thank you very much for speaking tonight.
Thanks very much, Natasha, and thanks everyone for staying up to listen in. I thought I'd give you now the liver update for children and during this COVID epidemic. Next slide, thanks. So in children, I mean, and as Fiona noted, mostly have mild symptoms, flu-like symptoms, fever, cough, gastrointestinal symptoms. The reported cases are thought to be less than 10%, which is probably an underestimate because children don't get sick, and it may even be completely asymptomatic, even though they've been infected. It's clear that there's very high rates of household transmission, more than 50%, which is probably also an underestimate. And probably the most feared complication that we in paediatrics in general, I'm not talking about transplant specifically, but paediatrics in general, is this so-called multi-system inflammatory syndrome, which is rare, but it's serious. It has cardiac manifestations. and a report from the United States in July noted over 4,000 cases, of whom 35 had died. And it seems like in the adults there's this cytokine storm where your immune system gets revved up by the virus, and that's what causes a lot of the disease associated with COVID-19 infection. In terms of the liver, certainly you can get inflammation of the liver or hepatitis, although it's uncommon. What we've recognised more so in the adult patients, but also in some paediatric reports, is that if you have underlying liver disease, underlying cirrhosis, say if you're waiting for transplant, if you're obese or you have fatty liver disease, that's a significant risk factor. And sometimes some people wonder about the side effects of drugs that are used for COVID-19 that may also affect the liver. There are reports of significant liver injury or liver failure, but all those children made a full recovery and had a good long-term prognosis. Now, in terms of what happens after children have had a liver transplant, the experience in Australia is pretty small because we just haven't seen it. And you know, I did a straw poll of all my colleagues around the country because there's no published data. In New South Wales, we haven't had any cases in our unit here in Sydney. We have had a family where a father who's a taxi driver had 2 episodes of COVID and isolated at home, but his young transplanted child was unaffected. Victoria had three cases of older children, adolescents, more than 7 years post-transplant, 2 of whom were unvaccinated. One of those ended up in hospital for a few days with constitutional symptoms, which resolved, and the other 2 were managed at home. And it's clear that because children lack these comorbidities, they don't tend to be obese, they don't tend to have diabetes, cardiac disease, hypertension. So they seem to be less likely to either be infected or certainly less likely to become significantly unwell. And it certainly appears that the dreaded multi-system inflammatory syndrome seems less likely in children after liver transplant. And some people have postulated that maybe the cytokine storm that I mentioned that causes a lot of the disease from COVID-19 is abrogated somewhat by immunosuppression. Not that you would run around and give everyone immunosuppression. Next one, thanks. This was a international cohort study published in the Journal of Paediatric Gastroenterology and Nutrition in earlier this year, and it looked at a number of centres in the US and Canada, and also I think South America, and it actually identified that if you look at the graph on the right and the arrows, you can see that in the light shading that liver transplant recipients were less likely to be hospitalised. If they were hospitalised, they were less likely to end up in the intensive care, and with no death rates. And the death rates were very low, as you might expect. And so that they came to the conclusion that the intensity of immunosuppression wasn't associated with worse outcomes or increased mortality. And again, they pondered this potential role of drugs like tacrolimus in mitigating disease severity, but that as yet is unproven. Next slide, thanks. As Fiona has detailed, vaccinations work. And this paper was actually from last week from the New England Journal of Medicine, so it's hot off the press. It's topical for us at the moment because it looked at children, these are non-transplant children, but children aged 5 to 11. They received 2 doses of the Pfizer vaccine. It was the doses that used are 10 microgram doses compared to the usual 30 microgram doses in the 12 and above year group and adults. And it demonstrated, if you look at the graph on the right, that COVID infection the incidence of COVID infection was dramatically higher in those who didn't receive any vaccination versus those who did. And although we are waiting here in Australia, official, or in New South Wales, well, I think around the country for official approval, it looks like it's coming at the start of January from both the TGA and ATAGI, so that children aged 5 to 11 can be vaccinated, and that will include post-transplant children. Next slide, thanks. And again, to reiterate, this is exactly the same slide from the New England Journal that Fiona just showed, just to really emphasise that although this was a study in adults after solid organ transplant, it demonstrated that a month after the third dose, the antibody responses had gone up to 67% compared to 40% after the second dose. So it emphasises, you know, the importance of 3 doses in the transplant population. It also highlights, as Fiona pointed out, that still around 30% aren't completely protected, and also need to employ all the other usual measures of masks and washing hands and being careful where you go. Vaccine side effects in children tend to be mild. Local reactions at the injection site. There's no evidence that you are likely to get rejection after receiving a vaccination. The dreaded side effects that were reported early on in adults, particularly the TTS, the thrombosis, thrombocytopenia syndrome, where adults were presenting with brain hemorrhages, and a small percentage of whom died. I haven't seen reported in children, and it seems to have been confined to that older age group with the AstraZeneca. There have been some recent reports about the incidence of developing pericarditis or myocarditis, which is inflammation of the heart muscle or the sac around the heart. Again, this is uncommon, associated with the Pfizer or Moderna vaccines, particularly in younger males after the second dose, but the symptoms are reported to be mild and not associated with any long-term sequelae. Next slide, thanks. There are potential treatments for children. We haven't had to use them in our liver patients. I noted that some of the renal patients Fiona reported had either an antiviral therapy, remdesivir. I think that was the one that Donald Trump went into hospital to have. This would be reserved for hospitalised patients, IV therapy for 10 days, and that's been shown to be effective in reducing recovery time and earlier discharge and preventing disease regression. And the same for the monoclonal antibodies, which are for the higher risk patients, although they have to be given within 5 days of symptom onset. I'll just note, you know, ivermectin is not a treatment. I know it's been touted in the press, including here in Sydney by a prominent physician. It doesn't work, and it has toxic side effects. Next slide. So as we open up in Australia, and it's certainly happening in the eastern states, and it's going to come in the other states, there's a number of knowns and unknowns. To quote Donald Rumsfeld, the importance of vaccination, we know both before and after transplant. It appears that it's important to vaccinate after 5 years of age, as I showed you from that recent study, and that's coming early next year. The importance, obviously, of mask wearing, hand washing, isolating, and also the importance of that we need to still see you. We've been doing a lot of telehealth the last 12 months. Hopefully we'll get back to more and more face-to-face, but it's important that we do keep in touch, that we do maintain our usual follow-ups, our usual vaccinations for all the other diseases, including influenza. The unknowns, well, we don't know about children under 5 years of age, and I know studies are underway overseas around this. We don't know what's going to happen in the future. Are we going to have booster shots like we do with influenza? We know that there's the development of rapid antigen testing kits. We don't know how accurate they are and what role that's going to play in helping us open up and be safe. And also the factor of getting back to school and using public transport in young, particularly unvaccinated children. The final slide. I guess one of the biggest questions we get asked and our nurses get asked is, can my child or should my child go back to school or daycare? And it's in some ways a difficult question to answer. There's the yes group. I mean, clearly, we do suggest that certainly vaccinated children go back to school. We know that there's improved herd immunity. We know that teachers are vaccinated, and we know that that's really important for children to learn, to socially interact, for their mental health, if not for their parents' mental health. And parents have work commitments and lives to lead. So there's certainly strong indications that that group should go back to school. Wearing a mask and social distancing would seem somewhat counterintuitive in children going to school, particularly primary school children, although I know that, my eldest daughter, who's 16, 17, she has to go to school and wear a mask. She can do it, but primary school kids, I imagine, would be very, very difficult to maintain. Maybe the no's would be those on a high level of immunosuppression, those who are early post-transplant, who are likely to also be highly immunosuppressed. And there may be various individual circumstances, or those who would prefer to wait for vaccinations. Thank you for listening, and I'm sure there'll be some questions around these issues.
Thanks very much, Michael. We'll move on to the next speaker, which is Rob Carroll. So Rob Carroll's a nephrologist at the Royal Adelaide Hospital. He's also a consultant to the Red Cross and tissue typing service. Thanks very much, Rob.
Thank you, and thanks for everybody for the opportunity to speak. And I'm sort of talking with my sort of transition young adult hat on, doing some work with the Women's and Children's Hospital in Adelaide. So next slide, please. So I just want to sort of concur with Michael and Fiona that really bad outcomes due to COVID in young adults, even if we sort of talk about adolescents in that sort of 15 to 18 group, is not that bad. And of the deaths that have been registered in New South Wales or in Australia, then there's been none in the under the age of 20. And even worldwide, it's a very, very small proportion of all the deaths due to COVID. So it's really to try to reassure you that from some aspects, things are not so bad in terms of COVID. This is really to remind you, however, that there are other shades of grey in between that. And this was the early data from the year in the UK. And it goes back to Fiona's comment that some of these people already had sort of natural immunity but got reinfected, and so they sort of got COVID a second or a third time. And in the UK, in that age group, there were 500,000 infections, and there were hospital admissions but not very many, and some people did end up in ICU. And in that age group there were a number of deaths, but this is really in the sort of pre-mass vaccination stage. And this is data from the US, where they looked at all of the registered paediatric or less than 18 admissions to hospital, ventilation and outcomes. And again, sort of concurs with what Michael wrote, that really it's these congenital cardiac abnormalities, obesity, type 1 diabetes, and there was a bit of a signal in this as well from asthma, but really other than those major issues, really transplantation didn't really register as a major risk factor for admission to hospital, which concurs with Michael's data. The other comment here, and I've got my sort of young adult hat on, is that even when people get infected with COVID and get sick and they don't end up in ICU, or they don't end up doing worse than that, there is a significant minority of these young people, so I call these young adults the sort of 18 to 25, 26-year-olds group, that were so sort of negatively impacted by the illness that they essentially couldn't look after themselves. And you would expect that this is the general population to be able to look after themselves. It's just another cautionary note that once you sort of get out of that teenage years and into what I call young adulthood, that really you can still be adversely affected by, so this is probably linking into long COVID. Next slide. And this goes, and this is cited directly from the ATAGI website when you actually read some of the issues that they've highlighted with regards to adolescence. And so they really sort of start to draw a distinction between how good the immune system of the general population is. And the immune system seems to be different in a 12 to 15-year-old as it is into a 16 or 18 to 25-year-old. So it's just sort of reminding everybody that we're reassuring ourselves that vaccination works in the 12 to 15 group and also in the 16 to 25, but there are differences, and whether that is then impacted on by what Fiona presented, but it's reassuring that after 3 doses, we're getting high levels of antibody production in transplant patients. And really that, you know, in the general population, in that 16 to 18-year-old group was really good at stopping symptomatic infection or hospitalization, and no deaths in the vaccinated population, in the general population. Next slide, please. And this is really to put things into perspective. There's been millions and millions of adolescents being vaccinated now across the world, predominantly with Pfizer and now more commonly with Moderna. And as Michael said, it's more common in males following the second dose, and ostensibly that it seems to be in the older teenagers or the young adults. So it's still 70 cases, but that's per million people vaccinated. And for females, it seems to be very much lower. And as Michael mentioned, even if they are symptomatic, it's usually self-limiting. And again, it's been seen with both the mRNA vaccines, but very, very rare. This is data from Canada, and Canada's experienced 1, 2, 3, and now they're in their 4th wave of COVID. And Canada did very well initially with their vaccination program. And this is data from Transplant Canada. This is one province. So this is like Manitoba. It's one of the central provinces in Canada. It's probably got a population or a transplant population similar to South Australia. And what we wanted to show here was that the bulk of people who survived were young in the black dots, and the people who actually died were relatively old or older. But in the blue and the red dots, it's just to show you that they've still had people over the age of 60 who've been double vaccinated, who have then had COVID and subsequently died of that infection. So being doubly vaccinated, which goes back to both the data that Michael and Fiona presented, is that there are some people even doubly vaccinated who are relatively aged or on the older side have experienced death after COVID. They have actually had one death in a 20-year-old who was not vaccinated. And this sort of demographic is pretty much replicated in when you talk to the Texas transplant programs and the Edmonton programs. And what I wanted to show here is that also the pediatric groups that haven't really had any major issues with pediatric groups in those 3 areas. So next slide, please. And this is really just to sort of show you that they're still getting people problems, and that it's taken them a number of times to get doubly vaccinated. So just a caution that in older people over the age of 18, so this includes my young adult group from 18 to 26, is that they don't need to be complacent. They do need to be boosted, and they do need to, again, you know, be cognizant of mask wearing, hygiene, and social distancing. So next slide. So really, I'm talking about young adults here. So that sort of 18 to 26 group. There doesn't seem to be a huge signal that there are bad outcomes, but they can still be requirement for ventilation, and that vaccines are highly effective in the general population, and also it seems that reasonably good in the younger people who've had 3 doses, and the risk of myocarditis is low. And again, it's this issue of talking to the other transplant groups in other countries where they've had essentially widespread community transmission. What they're asking people to do is making sure that their family members are all vaccinated, that brothers and sisters and mums and dads are vaccinated. And the other thing that most people are doing in sort of Edmonton, Manitoba and Texas is they're having their sort of bubbles of people who have been vaccinated that they go and socialise with. So thank you for your time.
Thank you, Rob. So we're going to start with the questions that have been sent in by people interested in this webinar. So thank you very much for putting that time and effort for doing that. I'm going to actually open the questions to all of the panel. So Rob, Michael and Fiona. So just to kick off with, obviously there's a lot of enthusiasm regarding vaccinating kids between the ages of 5 and 12. And that will hopefully happen between, starting in January of 2022. Some generic advice in terms of vaccinating transplant recipients who are kids.
So it sounds to me that from comments made that there will be a priority of immunosuppressed and transplant and dialysis patients in that 5 to 12-year-old group ahead of, children with normal immune system. So I think you do want to get those letters from your transplant units and get that done, as soon as you can. Book it in as soon as you can. That's basically the major message about that.
Yeah, I'd agree. Just be ready to get them booked in for vaccination.
Yeah.
And it's lucky that, it isn't, schools are breaking up soon, and, there's time you've probably got time to keep people away from people and wait until vaccination comes.
Michael, did you have a comment you wanted to add to that?
Oh, no, just that I think that those patients should get prioritised as seemed to happen, with the earlier cohort. The older cohort.
Mm.
So, Fiona and Michael, you both showed evidence of antibodies post-vaccination and time after vaccination and after doses. So, I guess I'm interested to know, here at Westmead, we are not measuring antibody levels. I guess I'd like to know from the panel whether your departments are as well, whether you think that might be useful going forward, whether it might be useful in determining if people need ongoing doses, or whether in fact we just say everyone's got to have an annual COVID vaccination.
We're not measuring antibody levels. No, I think it's been confined to the research sphere. I think there's some. I mean, having antibodies is clearly good, but there are also a bunch of other infectious disease, like I think, say, hepatitis B, where people are fully vaccinated and they may not have a demonstrable antibody, yet if they get exposed to the virus, they can mount an immune response. So that would be my kind of comparison in that regard. I don't know the answer about, maybe research will tell us as we go along, the issue of annual vaccinations depending on antibodies, but I don't think it'll be used in routine practice.
Yeah, I agree with that, Natasha. We're not doing it either. There's as you know, there's a real problem in variability of those levels and the different assays.
Yeah.
And so it's not reliable enough to be able to assess response just on that. So it's very much done as a research tool. And as I sort of showed from that slide when we were talking about vaccines and how you respond to them, it's a two-pronged thing. It's what are your B cells doing, so making antibodies, but also what are your T cell responses to the vaccine, as Michael was alluding to with, you know, responding to other vaccinations. So, and that's much harder to measure. So the safer approach is to allow research studies to inform us, which they have, and to make our recommendations based on the very controlled sort of research studies rather than measuring them in practice.
I'd agree with Fiona and Michael. I mean, ATAGI does say that both the sort of T-cell assays and antibody responses shouldn't really be used clinically at the moment to judge vaccine response. And I think it should be in the research portfolio. And again, it does seem that over and above sort of vaccine levels, it does seem that there may be a better immunity than just based with predictions based on antibodies or T cell responses alone. So it goes back to Michael's comment about you might not have antibodies, but you may well develop a T cell response or a response when it actually comes to infection. And you shouldn't be falsely reassured that everything's fine just because you've got high antibody levels. And that's the other issue. We don't want to falsely reassure people to relax when it comes to social distancing and hygiene just because they think they've got loads and loads of antibodies. That would also be, you know, unwise.
Yeah, that's a good point. There are a couple of questions that have come through regarding the effect of vaccines on graft function, and I know that was covered in some of the talks, but for the purpose of people who may have tuned in slightly later, would the panel just like to reiterate that, you know, your previous comments about the effect or the no effect has been seen on graft function?
Yeah. So no rejection, no increase, rejection rates across the board really, or changes in graft function. So with vaccination, but certainly with COVID infection, getting infected, not vaccinated, we've seen deterioration in function.
Yeah, and
yep, I agree.
And acute kidney injury in COVID.
That's right.
Disease, and please don't manipulate your immunosuppression. Don't change anything.
There was one question about side effects related to the vaccine and when vaccinated people experiencing side effects should present, you know, what are significant symptoms that might prompt people to seek medical attention. Are there any particular flags that people should be watching out for?
Well, I guess, I mean, fevers can be a common vaccine side effect. Fever is also a red flag for our immunosuppressed patients. So we'd have a low threshold to, you know, have children at least present and be assessed just to make sure there's no other cause for fever. I mean, as I mentioned in my slides, the side effects seem sort of more minor and local, but you know, I guess anything's possible with a vaccine. But generally, they're very safe. But so to answer the question, yes, it'd be ideally if there's any doubt, then the child should be, you know, presented to either to, you know, we get contacted or their GP or to the emergency department.
Michael, you talked a little bit about, you know, should you go to school? Should you not go to school? So in the under 12s who are not eligible for vaccination, what would be your recommendation? And I guess there's a couple of different variables. You've got a potential transplant recipient or siblings of a potential transplant recipient. What would be the panel's recommendation about going to school, continuing online school until you've got more of that primary school population vaccinated?
We've started to suggest that, you know, children can go to school, I mean, there clearly are, you know, risks in that unvaccinated group, but it needs to be weighed up with all the benefits of school and in the setting of improved herd immunity. You know, teachers are vaccinated. So in general, we've advised families that it is safe for their children to go to school, but equally I understand some people aren't comfortable with that advice. And I think, you know, expecting primary school children to wear masks is probably a little bit optimistic for all the day. So that's been our approach, but it's sort of more pragmatic than based on, you know, good evidence. But we think it's certainly safer than it was 12 months ago.
Yeah, I think it's been one of the most difficult things for us to really work this one out. And I think it has to be somewhat individualised, Natasha. You know, if you're fresh post-transplant, then that probably really isn't a good idea. If you're on the waiting list and you're about to have a transplant, maybe again, that's a period when you don't want to become exposed. I would definitely say have a conversation with your transplant team, because they'll know the individual specifics of your, you know, have you just had lots of anti-rejection therapy and you're more immunosuppressed? So I think you have to have that conversation with your team. But I agree in the general principle with Michael that the educational and social benefits of schooling do largely outweigh the risks here, because it is a milder disease. But, you know, we really need to think about all these things, and we do understand reservation of families about it. And I think this is a shared decision. This is a shared decision between the health professionals and the families here, very much so.
Yeah, and I think there's some questions that have come through on the Q&A, just not just pertaining to schooling, but also with regard to, you know, the festive season and school holidays and kids interacting outside of that. And I guess they're probably in a situation that's less control, environments are less controlled. There's not going to be mask mandates. So I think the advice that individuals should seek advice from their transplant teams is important.
And I think you have to evaluate it. I mean, we're talking about, say, the educational social benefits of school, but I'm not sure that there's the same benefit going to a crowded shopping centre. So you know, really think about the risk benefit of that kind of thing. And Rob was talking about, you know, bubble sort of socialising, where you're aware of the fact that the people you're mixing with are vaccinated. So you can consider that. Obviously, wherever possible, try and have your socialising outdoor, have it in parks, have it outdoors, you know, minimise your risks there.
Yeah, I agree with the team. Outdoors, it's going to be hopefully towards Christmas, good weather, but again, what a lot of people in the US summer did was they just made sure that the people they went with or have socializing with, they knew they're all vaccinated, and just did it that way. I think it's a sort of pragmatic approach to getting some form of socialization.
And any advice? There's a couple of questions about which vaccine is the best one. I don't know that that's an answerable question. Anyone care to weigh in?
Or maybe not AstraZeneca.
Well, it's not they're not eligible age-wise anyway. I mean, they're really the only ones on offer, you know, the mRNA vaccines, Pfizer and Moderna, and they're, you know, pretty similar. Yeah. I think
they're what's recommended, aren't they?
You can get the vaccine that you can get.
I mean, Rob, you talked about the myocarditis risk. There's one particular question with regard to somebody who might have a pre-existing cardiac condition that might be separate from their transplant status. I suspect that there's not that much data out there in terms of dividing people according to risk. You know, if you have a heart condition, are you more likely to get myocarditis or not?
It hasn't seemingly come through, but I do know that we've had chats to the cardiologists and the infectious disease doctors you know, at the Royal Adelaide when we've had issues, you know, we've had people with lupus who are immunosuppressed, who've got, you know, pericarditis, and then we've sort of discussed it with the cardiologists and the you know, vaccine doctors essentially. So we've taken specialist advice at that point.
It seems that from my reading of the literature, I mean, we've had no experience here, but if you do get pericarditis or myocarditis, it tends to be a mild disease. Don't think it's associated with a significant long-term cardiac issues.
Yeah, and of course the pericarditis, myocarditis that you get from COVID infection is a far, far more serious, you know, problem.
Yeah, and you know, in the first wave, I've looked after people with pretty significant myocardial scarring because there was no vaccination. They got a primary disease, and you know, in the young adult population in that 26 to 30 group, it's really been significant. Some of the damage that has happened from primary COVID infection, not the vaccination. So it's much worse to get COVID and get myocardial damage from that than it is from what is a tiny risk. You know, it's a tiny risk from vaccination.
And any information about long COVID in particular? Obviously, we know that COVID's bad. Long COVID is also bad. Given the difference in disease manifestation between adults and kids, is anyone aware of any data in terms of the risk of long COVID?
I'm certainly not in paediatric kidneys. No.
So the estimated proportion has been about 10%, but I think that probably will increase, particularly as we learn more about the long-term effects. We're almost out of time. Does anyone on the panel have any further comments that they want to make?
Well, just thanks to all our patients and families for their forbearance. It's been really tricky time for them, I know, and dealing with all these uncertainties and the changing medical advice and telehealth, although I think they love telehealth, so they don't have to come and see us. And we look forward to seeing you face to face soon.
Well, thank you to our panel, Fiona Mackey, Rob Carroll and Michael Stillman. And thanks to everyone for attending. I'm going to hand back to Colin Liebman.
Thanks, Natasha.
Thank you.
Thanks, Natasha.
Thanks, Natasha, and thank you to all of our panelists for giving us your time and your insights and your most up-to-date information. When I reflect on the first webinar that we had, I think it was in February this year, when so much was unknown, when the advice was on balance, it was probably better to become vaccinated, but so much of, you know, the effects and the benefit were unknown, and we seem to have come a very long way in 9 or 10 months. And I think you know, we're so thankful for your time tonight. We're privileged that you can share with us the most up-to-date information from around the world. It really is so reassuring for families to hear such up-to-date information. So thank you all for speaking. Thank you everyone who dialed in tonight. I encourage you to check out the Transplant Australia website, keep up to date. There will be further webinars and activities, and you know, we look forward to welcoming you again to future webinars. And everyone stay well, and thank you. Good night.